So thank you very much for the kind invitation to come and speak at this conference. It's actually fun to be part of a co-infection side seminar or side bit of this meeting. So I hope that everyone at the end of this becomes very interested in TB meningitis. Certainly we need people who are interested in tuberculosis in general to help in the field. Is it this one? This one, yes. Okay, great. So just to set the stage a little bit for childhood TB, there's been a renewed interest in childhood TB. Up until 2012, WHO didn't even report childhood TB cases or the incidence or prevalence of childhood TB. I think that the rationale was that, well, it's really hard to diagnose. We don't know how well children do with the disease. It's not really a public health risk because they tend not to have pulmonary disease and be the spreaders of disease. And so it really wasn't thought to be a public health problem. And so there was a real period of historic neglect that I think is now, things are changing now since around 2012 when this roadmap for childhood tuberculosis came out. But there's probably about 500,000 cases in 2012 and about 75,000 deaths from TB yearly. And that's among children without HIV, so certainly much higher numbers if you include children who also have HIV co-infection. And so the title of this talk actually, which is interesting, is Controversies in TB Meningitis. And so when you think about things that are controversial, you don't really think about TB meningitis, but I thought, okay, well that's that's a nice challenge to try to make this seem kind of full of intrigue and drama. So I'm gonna see if I can do that over the course of this talk. And so actually when you think about what are the controversies, there are actually quite a number. So I put together sort of a couple of columns. So why should we be interested in TB meningitis as a research community? And then the con side is, well, why bother, right? And so there actually are a lot of funders who will say that since children don't spend the disease, we shouldn't focus on pediatric TB. And so pediatric TB has typically been underfunded both in the research arena and in the public health arena. But since young children are overrepresented among those individuals who get disseminated TB and who die from TB, if one of our goals is to reduce mortality from TB, then certainly we need to start looking at children, and particularly young children. We don't really understand if in many TB endemic settings in the world, we don't really see a lot of meningitis, and yet in other settings in the world, we see a lot of it, and we don't really understand why there are these pockets of disease. And some people would say that's not really worthy of our interest because, well, it's just underdiagnosed in some places. It must be there, but we're just not finding it. There are really some very promising diagnostic tests that are becoming available for diagnosing TB meningitis. The why bother community would say, well, diagnosing TBM in adults is really hard. Diagnosing TB in general in children is very hard. Diagnosing TB meningitis in children, forget about it. Way too difficult. We lack biomarkers that allow us to assess treatment response, so that makes it difficult in individual patients to adjust our treatment, and then it also makes it very difficult to conduct clinical trials because we really don't have anything to measure. So that means that it's really an important area of research. And then, so someone might say, well, biomarkers are unlikely to be actionable, and they probably won't predict outcomes any better than stage of disease. So why look at these biomarkers? Optimization of antimicrobial therapy for TB meningitis is an urgent need. Also, adjunctive host-directed therapy should be studied. We really don't know what the right drugs are, what the right doses are, what the right combination is, or what the right duration of TB meningitis treatment is. So these are broad knowledge gaps in treatment of pediatric TB meningitis. But some people would say, you know what, by the time you diagnose TBM, it's too late. The damage is done. The antimicrobials are just not going to make any difference. So really, that's not where our focus should be. It should be on ICU care or supportive care, these sort of things. TB meningitis is very different from pulmonary TB, and so our treatment strategies have to be very different and focused on getting the drugs to where the bugs are and attacking the inflammatory response. And then other people would say, look, TB is TB. Just give the same drugs, but just give them a bit longer because it's a harder disease to treat. I would say that we need to find the best treatment for children specifically. in TB historically, we find a treatment that works for adults, and then we look to see what doses of drugs we need to give to achieve adult equivalent exposures, and then we give the same drugs for the same duration to children. And, but I would say that for children specifically, we need to look at TB meningitis and efficacy, not just drug concentrations. And then TB meningitis in HIV-infected persons has especially high mortality. There has to be some benefit of early antiretroviral treatment, which now is considered contraindicated. But we don't know who those people are who might potentially benefit. So I would argue that TB meningitis is an important area of research, but there are really a lot of naysayers who feel like it's just too hard and maybe we shouldn't bother. Okay, so let's just talk about what is the evidence that we have so far. So who gets TB meningitis? Are there genetic determinants of risk and of severity? And can these be used to direct interventions? So we know that TB meningitis typically develops within a year of infection. So these are typically household contacts of cases. And the people who are at the highest risk of disseminated TB meningitis are, as you know, very young children, so under the age of 3, under the age of 5. And then individuals with HIV co-infection, and then malnourished children. There's a lot of geographic variability in incidence. And then we know that for children and for adults as well, that typically people will present very late stage. So not stage 1, where they're not focal neurologic signs and an intact sensorium where it's very easy to treat, but generally it's a hard diagnosis to make. And so people will present very late, in late stage. And so there was some hope that there was this marker for genetic predisposition, both to getting TB meningitis, to having severe disease, and then that would predict whether or not you could potentially respond to steroids. And so this was some work done in zebrafish. And so, I don't know if you know zebrafish, but they're see-through, and they're really susceptible to mycobacterial disease, so you can kind of see how much disease they get just looking through them. And so you can quantify disease, and then you can change, their genetics, and then see how susceptible they are to disease, and do these different very interesting things. And so they discovered that this LTA4H gene seemed to be associated with susceptibility to TB meningitis, and then to mortality related to TB meningitis. And so the thought is that if you have sorry, let's go to the next slide. So if you have a homozygous TT genotype, that you are hyperinflammatory. And so it makes sense that if your response to TB meningitis is hyperinflammatory, that perhaps steroids might help you. And then there's this group that is pauci-inflammatory, and that is the CC homozygous genotype. And so those people would not benefit from steroids and maybe would have higher mortality. And so what you want is to have this genotype that's the just right genotype, right? And so they had some initial studies that looking at patients who were homozygous versus heterozygous, and it looked like, you can see from this graph here, that people who were in the just right inflammatory response seemed to do better. But then when the same group went to look at whether or not steroids preferentially improve the outcomes among individuals that had a hyperinflammatory genotype, it turned out, you can see from the solid lines here, that steroids didn't seem to impart a benefit to those individuals with the hyperinflammatory genotype. So unfortunately, although we were hopeful that this might potentially be something that gives us some idea of risk of disease and the type of inflammatory response people have, it didn't so far turn out to be very helpful. So what's the pathogenesis of TB meningitis? Can we really even expect that if we give better antimicrobial treatment, if we optimize the antibiotics that we give, that we can make any difference? And so I won't belabor the pathophysiology, but we all know that TB meningitis is disseminated TB, and it lodges in the meninges, and then gradually this breaks down, these rich foci, and then you develop meningitis. And there's a really hyperinflammatory response. And so the clinical consequences are catastrophic. Dense meningeal exudate with adhesions. This leads to hydrocephalus, cranial nerve defects. And you can see from the slides on the top right from Dr. Gaji, who's from University of Cape Town, just these dense exudates when he does neurosurgery on these children who are suffering from TB meningitis. And when you see him show the videos of the surgeries, it's really very dramatic. It leads to obliterative vasculitis, so these children suffer strokes, and then encephalitis and myelitis that leads to reduced consciousness. So the question is whether giving better antibiotics is actually going to help any of these terrible outcomes. And so then the next question is, well, do we need to study TB meningitis specifically in children? Why not just study it in adults? Maybe you'll find it more commonly, and it's easier to do studies in adults generally. And I would argue that the treatment outcomes in children and adults are actually very different. And this is a meta-analysis that looked just at children with pediatric TB meningitis, and the risk of death from TB meningitis is about 20%. And then among those children who survive the disease, about 50% have long-term neurologic sequelae. So it's a terrible disease, but actually among adults who have TB meningitis, the mortality is higher. It's more in the 50 to 60%. So I think that children actually, even though they fare poorly, they fare less poorly than adults. And you can see just from this meta-analysis that there were 27 different TB meningitis regimens used in the studies that they were able to pull together. There are no randomized clinical trials among these observational studies in this meta-analysis. And so then the other question is, what does TB meningitis do to the developing brain? Because unlike adults, children who have TB meningitis, they're young, their brains are developing, it's a really important time of neurocognitive development. And so, what happens? It's a long disease and it takes a long treatment to get it better. And so what happens to children who have TB meningitis? I think the data are quite sparse, especially looking at really long-term outcomes, so 18 months, 24 months, and longer after TB meningitis treatment. But we know that there are cognitive and gross motor impairments, behavioral difficulties, and emotional problems. So I would argue that studying the disease in children is certainly an imperative. So that's great, let's study the disease in children, but can we even diagnose it? So yeah, so if you want to work on something hard, work on TB meningitis. So before this 2010 article came out, there really just wasn't any consensus way to diagnose TB meningitis. But then this group put out this paper in Lancet ID, and essentially you get points based on clinical criteria, CSF criteria, imaging results, evidence looking for TB elsewhere. Can you find it in the lungs? Can you find it in a lymph node, et cetera? And then they did a subsequent study to look at how does it perform. So among culture-confirmed TB meningitis, if you meet the definition of probable TB using this research definition, then that's 85% sensitive and 100% specific. So that's actually pretty good. And so if you have a clinical trial that has probable or definite TB meningitis as your inclusion criterion, you might feel relatively confident that those included children are likely to have the disease. And further, now GeneXpert, which you may know is these cartridge-based nucleus or NAT test, it has been now modified for use with CSF. So you can essentially take CSF, put it into the cartridge, put it into the machine, and this test has recently, the World Health Organization has recently recommended this as the first-line test to evaluate for TB meningitis. And you can see, as with most tuberculosis recommendation, it's a strong recommendation. Actually, that's relatively rare. Usually they're conditional. So it's a strong recommendation given based on very low-quality evidence. So, yeah. And also, I just saw a study that I thought was very interesting looking at this as a test in people who had already died to see whether the TB meningitis could be diagnosed post-mortem, and it had 100% sensitivity, and they say point-of-care tests have high accuracy to diagnose TBM in deceased HIV-infected adults, which I thought was one of the most interesting conclusion statements I've seen in a long time, so I thought I'd put it on this slide, even though it may not be relevant. All right, so how am I doing, Mark? Okay, good. So how do we treat TB meningitis? So how close are we to an optimized regimen? Okay, so there's been one clinical trial in pediatric TB meningitis ever in 1986, and it was an unsuccessful clinical trial. So since then, actually in all of time, there's never been a trial of in TB meningitis. And so how do we treat pulmonary TB? So essentially what we do is we use 4 drugs, as many in the room probably know, for 8 weeks for the intensive phase. So that's isoniazid, rifampin, pyrazinamide, and ethambutol. And then for a continuation phase, the next 4 months, we continue the isoniazid and the rifampin. And that's typically what we use. It's what we call short course TB treatment. So of those drugs in the TB regimen, each one actually has a bit of a different job. And so, but the one that is the most important, the one that kills those persister organisms that are really hard to kill, that are metabolically semi-dormant, is rifampin, right? So if you have MDR TB and your infecting organism is resistant to rifampin, your duration of treatment goes from 6 months to essentially 18 to 24 months. So rifampin is the drug we need, and we have nothing that can replace it in terms of sterilizing activity. And so that's important because when you think about TB meningitis, you have to get the drugs to where the bug is, right? And so isoniazid, that's fine. The CSF concentrations are about 80 to 100% of what you see in plasma, so that's great. Same thing for pyrazinamide, awesome. But then if you look at rifampin, it's about 10% the concentration in CSF as what you achieve in the plasma. And yet, the WHO recommends 2 months of isoniazid, rifampin, pyrazinamide, ethambutol at standard doses, and then just continuing the continuation phase, instead of stopping at 6 months, stopping at 12 months. So same drugs, same doses, just increase the duration. And yet, ethambutol does not get into CSF at all, whether your blood-brain barrier is inflamed or not, and rifampin gets in at very low concentrations. And rifampin is the drug you need. So what's the evidence base for this WHO recommendation? It certainly is not evidence-based. The other thing to know is that fluoroquinolones easily traverse the blood-brain barrier, so that might be a good option for TB meningitis. Okay, so what's the standard of care? Because if you're going to design a trial and you want to start to look at different treatments and figure out what's the optimized regimen, what's the standard of care? Well, it just sort of depends on where you are. It's because there have been no randomized clinical trials, the evidence base is poor, so no one really knows how to treat it. So people do the best they can to come up with national guidelines, but those national guidelines are very variable from country to country. So this all seems rather bleak, but then this trial came out. And this is by a group in Indonesia. This is a PK study. What they wanted to do was assess in patients who have, adult patients who have TB meningitis, if you increase the dose of rifampin from 450 milligrams to 600 milligrams, small increase, and you give it IV, what are the concentrations of the drug and what happens to people. And so in this really small PK study, they actually found that increasing the dose from 450 oral to 600 IV led to a 53% reduction in mortality. This is mortality. So it's not just the drugs were higher, we measured them in the CSF, they were now above the MIC, but they're typically not above their MIC. This is mortality. So people who did not have the higher dose had 65% mortality, and those people that had the higher dose given early in treatment had a 35% mortality. Small study, has not yet been replicated, there haven't been efforts to replicate it as of yet, but it gives us some hope that actually acting early and using antimicrobial therapy, we can actually do something. So it's maybe it's not too late. If we hit early, hit hard, maybe we can make a difference. And so there also have been some studies that are promising with fluoroquinolones. This is a PK/PD analysis that essentially showed if you have concentrations of fluoroquinolones that are within a certain range, that you have better outcomes in terms of disability and in terms of mortality than if you have low concentrations or you have high concentrations. And probably the high concentrations are because people who are very severely ill clear the drug less well, and they also have a less intact blood-brain barrier, so you can measure higher concentrations in the blood. It's not being renally cleared, and also in the CSF. So there seems to be a range of exposure that potentially could lead to reduced disability and mortality of fluoroquinolones. Okay, so then that's what we know so far about, like, what are some clues about what drugs might be helpful to improve the outcomes. And so now what about adjunctive therapy? Okay, good. So thalidomide. So people see thalidomide and people generally have a relatively visceral response, right? But thalidomide is now being used for different types of cutaneous vasculitis, other types of rheumatologic disease, and this group in South Africa has shown that tuberculomas, tubercular abscesses, and optochiasmic arachnoiditis that's refractory to antimicrobials, refractory to steroids, if you add thalidomide, that it actually helps. And these lesions tend to melt away. And this is just an example here, got it, of thalidomide in an individual with HIV who had a tuberculoma and then was started on antiretroviral treatment and had an inflammatory response, which you can see the white in the middle picture, and then was started on thalidomide and that went away. And so thalidomide is being sometimes used in the setting of virus in co-infected individuals, and then in these children, as reported by Showman et al. If there seems to be a narrow therapeutic window, they had a trial where they used high doses and had to be stopped early, but at these lower doses, it seems like it might potentially provide a benefit. Okay, so how can we run trials given the heterogeneity of disease? I mean, you have kids that just are fever and not, and behaviorally a little different, fussy, but then you also have kids who are in a coma, who have had strokes, who are very ill. And so it makes it really challenging to conduct any sort of clinical trial where you want to assess an intervention. And so, are there any biomarkers of treatment response? And really, this is a giant black box. See, it says this is a black box right there. So we really don't know if there are any sort of inflammatory markers, any sort of markers of neuronal injury that we could measure in CSF potentially that would give us some idea of if a treatment is working, because otherwise you have to have 800-person, 1,000-person trials to look at interventions, and how are you going to do that because the disease is just not that common and it's really hard to enroll these types of trials. So there are a lot of work that needs to be done in this area. Okay, so if we come back and we revisit these controversies, I think if I had everyone vote if they think that TB meningitis is a field that demands some attention and would be a good investment, I think people hopefully would say yes and vote for pro. I actually took the no column off, so you can't vote that anymore. But young children are really overrepresented among people who suffer from this disease. There's a giant gap in research dollars dedicated to this disease. The risk factors for development of TBM in TB endemic settings need to be identified and quantified. We need to come up with a better diagnostic algorithm, because there are all these studies you can do, but which ones should you do and in what order with a limited amount of CSF in sick children? How can we assess CSF inflammatory and neuronal damage, and are these biomarkers going to be helpful to us? What are the right drugs? What are the right doses? What is the right duration? What is the right combination? And is there any benefit to these adjunctive therapies? And how are we going to really get to that? And then assessment of treatment effects on child-specific outcomes, so really looking at neurologic outcomes in children and neurocognitive outcomes, and how long-term are these children going to fare in the world having suffered this disease as a young child. And so this is just a kind of a shameless plug for our trial called TBM Kids Trial. And so we're going to try to at least start with one trial looking at some of these questions. This is a phase 1/2 randomized open label trial to evaluate the PK safety and treatment outcomes of high-dose rifampin with or without levofloxacin versus standard treatment for pediatric TB meningitis. And so this is essentially the schema that children with suspected TB meningitis that meet the case definition for definite or probable will be randomized to either have high-dose rifampin together with other standard drugs versus high-dose rifampin with levofloxacin substituted for ethambutol, because levofloxacin gets into CSF well versus WHO standard of care. And so I won't belabor this too much because I only have 1 minute. But we'll be assessing modified Rankin scale for children. So this is kind of a different outcome measure than we're typically using for TB or for HIV. And we're also going to be using the Mullen scale of early learning to look at neurocognitive outcomes. We have a really wonderful collaborative team from Malawi and from India. And this is a really nice, NICHD funded this and believed in it and fought for this to be funded, so we're really very grateful for that. And I just want to say thank you for your attention.